Buenos dias, everybody. It's me again, and in the next 15 minutes, I have the pleasure to discuss elbow fracture management of post-fracture elbow problems. And again, there are no conflicts of interest of a couple of paid editorial tasks and national and international patents. Objectives in the next 14 minutes is to learn to manage difficult problems based on cases and outcome. And I have a few on different pathologies like stiffness, instability, implant failure, non-union, defect management, infection, and other things. Case number one, and have a closer look to fixation principles. In this case, Julia T has a 68-year-old diabetic patient after a fall, and she had this multifragmentary elbow fracture of her ulna, which was fixed with this plate. And when we have a closer look to the fixation, we see many screws in the distal main fragment and maybe 1.5 screws in the proximal main fragment. So it's somehow a disbalanced fixation, and the outcome is not very surprising. After several weeks, without any additional trauma, she developed this dislocation of her proximal fragment. But in addition, she also had soft tissue problems. The plate was showing up. She had a limited range of motion. So the question was, what should we do with her in this situation? First thing we did was to remove the implant, clean out the fracture site, insert an antibiotic spacer, and try to fix the short proximal fragment with more screws than in the initial surgery. But guess what? Again, we have the problems that the fixation in the proximal main fragment with the pull of the trapeze is significantly. So we had failure again, and went back to surgery to revise it. And the surgical steps are outlined on the left side. First, we leave the plate in the distal main, and we remove the proximal screws only. We find the proximal fragment unperfused and bone defects. The triceps gets a tenodesis to protect from further dislocation, and we thought this might be a case for a compression fixation with cerclage wires. We applied 2 compression cerclage wires, additional biology by adding BMP to the defect zone. And now the critical step comes, which is the reduction. This is done with the help of 2 large reduction clamps, so we can fine-tune the ulnar and the radial side at the same time with nicely adding or subtracting force to the clamps. And the important part is now coming. We close the cerclage wires, and we can fine-tune the compression on the radial and the ulnar side, and we can do it on 2 levels. This is the intraoperative X-ray, but it gets more clear with the post-op X-ray. So we have the patients 8 and 9 months after the revision surgery. We find the proximal main fragment has nicely stayed adapted to the distal main fragment. The 2 cerclage wires are here indicated on the CT scan, which demonstrates as a nice healing. And it is the course of the cerclage wires is outlined here. So there's one dorsal and one more proximal cerclage, which is figured around the locking screws to have very strong compression force which stayed over time. The temporary muscle fixation was removed after. So healing first is also true in the case of 62-year-old female patient referred actually for arthroplasty because the referring hospital thought this can't be fixed anymore. But we thought this might be worth trying. And the different steps of fixations are outlined here. Reduction clamp on the distal ulna after olecranon osteotomy, and the pull on the olecranon now gives full access to the distal main fragment articular surface. We insert the chisel, return it, insert the spacer, so we have completely loosened the fragments. Now we can reduce it, fine-tune it with K-wire, double plating and biplanar plating, and additional buttress on the dorsal side, distal fixation first, and now tension. The plate is tensioned with the reduction clamp before it is statically fixed with a locking screw. The difficult part is also additional fixation through the articular surface, which is done with the double differential screws on both sides, and the final cap of the radial capitulum is done by molding the reduction and an additional K-bar. Here's the postoperative X-rays, the postoperative CT scan, and it's very clear this is priority is healing first, no physiotherapy. We accept partial stiffness of the elbow because we found that we cannot achieve both targets, movement and fracture healing in this complex situation. So after 9 months, we went for the second step, arthrolysis. We did an anterior capsulectomy and regained full range of motion for extension and function. This is a patient 13 years follow-up after both surgery, with a very happy patient with full range of motion for extension and flexion, and also for internal and external rotation of the forearm in a patient which was submitted to us for our case. Shows a frequent problem which are articular defects. Where, like here, it was treated in Berlin, and we see that we have a large articular defect which was left alone. Patient was informed there is a defect. We can't do anything, but we thought after the patient showed up in our department because of significant pain when he did sports, that we can help. We harvested bone graft from the iliac crest, where we looked very good, close for the shape of the defect and the natural curvature. We fixed it with little screws and plates from the handset, and came back then several months later, once the bone was healed in, and added cartilage graft which was cultured in the lab for 4 weeks. So we had then this little cartilage particle which were covered with and sealed with a resorbable membrane left in place. Intense exercises without weight. Here's the 11-year follow-up. Excellent function, excellent elbow scores, including push-ups. Very happy patient. But what are we doing when we have larger defect, like in this gentleman with an O3B distal humerus and olecranon fracture with a large central defect after debridement, completely contused and contaminated fragment has to be removed, leaving a large central trochlear defect which requires actions. And the question is, what are the options here in this situation? And we think this is a case for 3D printed individualized joint implants resurfacing the defect area. Here's a postoperative situation with the central 3D printed implant and additional plate and screw and cerclage components in order to hold the construct together. This is a follow-up at 11 months. Range of motion is 0-30, 110 degree, and good daily activity is possible. But what are we doing if we have larger defects, like this patient from Kosovo with high energy gunshot elbow fracture, which presents with a stiff chronic MRSA infected elbow with significant pain and no function? Here, step number one is always the debridement of the soft tissue and bone, antibiotic cement spacer, vacuum sealing, redebridements until we have fresh bleeding, clean wounds and bone contact areas. And then this is followed with a large prosthesis, here a tumor prosthesis, leaving a large soft tissues defect as all. That's the usual combination of problems requiring latissimus dorsi free flap. Here's the soft tissue situation during the treatment course, and here the postoperative follow-up at 1 year, fast return of the functionality, and a good increase of the functionality for daily basic activities, but not possible for heavy load working activities anymore. And here is a patient with a combination of many problems in a very young patient. Catherine is 24 years old. She had a neglected radial head, fracture dislocation, failed extending corrective osteotomy, chronic anterior radial head dislocation, deformed radial head, deformed radial condyle, instability, deformity, and a limited range of motion, but worst of all, a significant pain level with a VAS of 6 to 8. So what are the options here in a 24-year-old We think this is a case for a joint transplantation with a fresh large allograft. You see here the graft with this anatomic structures, the elbow condyles, the radial head, and we harvested a graft out of the radial head with the dotted line, and also the joint surface to the ulna together with the annular ligament and the radial collateral ligament with a little bone chip in order to be able to fix it. Here's the intraoperative situation. We make the approach. We see the radial nerve in the biceps tendons. Here's the transplant with the intact ligamentous infrastructure. And this is prepared in order to get a small chip. The critical step is, does the radial basis bleed? This is the case, so we can continue. We form the radial condyle capitulum. We press on the excavated radial head so it has tight fit contact, and here a first test of the articulation. Still everything is unstable because the collateral ligament is still missing, but it is now fixed and tightened, so the annular ligament is slipping over the radial head, and the lateral collateral ligament is tightening it, and it's fixed with a bone chip. Here, the postoperative situation, the deformity from the osteotomy is corrected nicely, straight elbow again, and in the postoperative here for 2-year follow-up, we see a nicely centered radial head, good increase of range of motion, and a happy patient with a significant increase of mobility and functionality. So let me summarize. We have seen a variety of entities, olecranon and non-union. It's important to neutralize the dislocating forces. Triceps tenodesis allow movement without pull. Two-level compression cerclage is an option where screws don't work anymore. Good against pull-out and better than screws, and no physio until healing. Only self-directed exercises. Low fractures are a special entity. My priority is healing first. Don't get nervous about the range of motion, no physio. And then in a few months after healing, arthrolysis when bone healing has achieved in combination with an anterior capsulectomy. Small articular defects, autograft, cartilage transplant, medium defects, 3D printing is a new option which is very promising, and large defects, still the hinged arthroplasty is the way to go with a free flap, but it needs to be made sure that we have really a clean situation and special situation. An allograft joint transplantation might be helpful. Thank you very much for your attention.